This digital artifact will now discuss the case in relation to steps 3 to 5 of the 6-step framework of ethical reflection. Step 3. Who are the parties involved and what shapes their views. In this section I will explore the key parties involved in this situation, critically examining the values, needs and other factors that can shape different perspectives. The 3 core factors that influence ethical decision making regarding this case study would be capacity, professional responsibility and emotional or human factors. Firstly, the key party involved is patient X. During this time, patient X was experiencing acute psychosis with delusions that revolved around paranoid beliefs that staff were poisoning him, resulting in feelings of intense fear and mistrust. That resulted in patient X's refusal of antipsychotic medication, further altering patient X's ability to make informed decisions about treatment. Beauchamp and Childress 2019 states, autonomy relies on a person's ability to understand and voluntarily choose. However, in acute psychosis, the capacity is significantly impaired, meaning patient X's refusal cannot be considered autonomous. Cusack et al. 2018 found that many psychiatric inpatients experience restraint as frightening, humiliating, and deeply damaging to their trust. From patient X's perspective, being restrained reinforces his belief that staff intended to harm him, so while the intervention aimed to prevent harm, his subjective experience shaped how he interpreted it. The second party involved would be the other patients in the ward, as patient X provoked hostility by threatening other patients by raising a chair with violent intent. Bowers et al. Highlights exposure to aggression can increase fear, distress, and disrupts recovery from another patient's perspectives, putting their physical and psychological safety at immediate risk. This then highlights the ethical principle of justice, as fairness and equal protection for everyone in the ward should be assured, and staff have a duty to intervene accordingly to not just jeopardise the safety of other patients. Next, the nursing staff and wider MDT. During this incident, staff had attempted verbal de-escalation before the restraint took place. However, due to the intensity of the incident and pressures from patient X's fragile mental state, further action was then taken to diffuse the situation. As the Nursing Midwifery Council 2018 highlight, nurses are required to minimise harm and uphold dignity. However, in this case study, it was mentioned staff feeling uncomfortable taking part in this. As mentioned, Bigwood and Crow's 2016 study reports that nurses post-restraint often feel guilty and self-doubt, which can affect them both personally and ethically. However, Rahia et al. 2021 describes, although nurses may struggle to balance personal moral identity, they also inherit a way of managing this through a professional obligation to prevent harm. These human factors significantly shape real-time decision-making. Moreover, further organisational and legal frameworks are also in place to assure, under the correct pretences, that further restrictive practices could be permissible, as the Mental Health Act 2003 permits the use of restraint when deemed proportionate to prevent serious harm. However, this is as conflicts with the Human Rights Act 1998 that discusses any restriction on liberty must be lawful and least restrictive, alongside the Restraint Reduction Network 2021, and Kelly et al. 2023 found that there are irregularities in the frequency of physical restraint used across services, highlighting it can be very influenced as an organisational structure. Together, these perspectives show that impaired autonomy, staff's emotional and professional boundaries, and legal duties around the least restrictive practice all come into play to shape an ethical dilemma. Step 4. What values, principles and laws come into play? Step 4 will examine the ethical principles, values, laws and theories that frame the decision about whether restraint was ethically justified in patient X's case. A key issue underlying this dilemma is patient X's capacity to make safe and autonomous decisions during an episode of acute psychosis. As under the Mental Health Act 2003, all adults are presumed to have capacity unless legally shown otherwise. However, the Act also recognises capacity as decision specific and can fluctuate. During this incident, patient X's delusions prevented him from understanding the information about his medication, risks and intentions of staff, which Beauchamp and Childress 2019 explained that autonomy relies on the ability to understand and make voluntary choices, which were abilities that were both significantly compromised at the time, which created a barrier between patient X and staff, as the refusal of medication then further limited the decisions that could be made shortly after. In addition to capacity, ethical principles such as beneficence and non-maleficence are central. Staff must act in ways that promote patient X's well-being whilst also preventing harm. However, this principle becomes complex when every option involves potential harm, as restraint carries risks of trauma and trust. However, At this stage, inaction can also lead to imminent risk with the likelihood of serious injury to another patient. As Harris 2019 argues, restraint may be ethically defensible only when it is the least harmful and most proportionate option. In patient X's case, the threat of violence escalated rapidly, leaving any other non-intervention ethically unacceptable. Justice also plays a significant role, as in a communal ward, staff must always consider fairness and protection for all patients. As Beauchamp and Childress 2019 described, justice is providing equitable attention of risk and safety. By allowing patient X to continue threatening behaviour, would then be prioritising his autonomy over the rights and safety of other patients, furthermore compromising the NMC Code of Conduct of nurses' duty to maintain a safe and therapeutic environment. Alongside these four ethical principles, professional values and human factors shape how restraint decisions are made. Trust is an essential value that can be adversely affected, as Hem et al. 2018 report that restraint can be perceived by patients as punitive, frightening, and damaging to therapeutic relationships. This is particularly relevant for individuals like patient X, whose psychosis already shapes his perceptions of paranoia and threats of physical harm. Although restraint may prevent immediate harm, undermining trust can create long-term barriers to engagement and recovery. Ethical theories are also further layers to this analysis, as a deontological perspective illustrates actions such as restraint, due to the inflicting upon autonomy and bodily integrity, are morally wrong, regardless of the intention, and should only be used in extreme circumstances. Gillen 2015. Meaning, to preserve autonomy and preserving ethically sound practice, the least restrictive measures should be in place. However, utilitarianism demonstrates proactively that restraint in this case is morally right, as the results lead to the least overall harm. As a ratio of risk to harm to staff, other patients and themselves become exceedingly high as behaviours escalate. Steinhardt 2020 supports this with nothing is unjustifiable regarding restrictive practices when preventing greater harm to multiple individuals. Together, these values, emotional pressures, and ethical theories demonstrate the complexity of this dilemma. Staff had to balance autonomy with immediate safety, therapeutic relationships with risk management, and their own moral discomfort with legal and professional responsibilities.